So am I good? You see my screen?
Yes.
Okay, awesome. So welcome everybody. They're coming in. Welcome to our session tonight. We're going to give everybody a few minutes to join us. So, oh, there they come. You see the numbers as they come in. Let's see who's coming in here. Who do we know? See our friends in here. Oh, so it looks like
Hey, Melissa's in.
she is in. She's just Melissa. You can put your video cam on. There we go.
Hi, Melissa.
It is awesome.
I don't look very good today. I know there's other people on. I was at work. I'm like, oh,
Everybody's watching you, so they're coming on and they can all see.
I know. I'm happy to be here. I'm very happy.
Melissa, you look stunning. Melissa, you look beautiful as always. Come on.
We're gonna. It's 7:30, but we're gonna give it a few minutes because people are just coming in.
You look like you just helped with a baby. You know, you just like.
Sort of did.
Did you just help the baby? I can't even think of the word. Deliver. Thank you. Oh my gosh.
Help with the baby works also.
Help with the babies. Deliver a baby.
That's what I do.
Exactly.
That's why people are on here with you guys.
So Melissa, you just might want to aim your camera down a little more. There you go. Perfect.
Is that good?
Yeah, there you go. Awesome. Now you look like more than just a head, so that's great. So we're gonna give it a couple of minutes. We got people coming in. So Helene is in the chat. You can tell her where you're from. She likes to hear. We have our group here is pretty East Coast centric, aren't we?
Yes.
I'm in Florida, and Maya's Ohio. That's sort of Midwest. It's not that East.
Ohio's Midwest.
And
Oh,
Helene,
hi, Maya.
Hey.
and Dr. Russo's in Rhode Island.
Melissa, too. You
Yep.
call me Melissa.
In Rhode Island. So we have a few more people joining, so we'll give it another minute or two and we'll get going. We have a lot to cover tonight. I know you have a lot of questions. So we'll give it one more minute and then we'll start. So we will get started. It's about 7:32, and we know people will be joining throughout, but let's do this. So officially, we are starting now, and my name is Eileen Michelli, and I'm the Chief Program Officer for the Marfan Foundation. I also want to introduce my colleague Helene Baruch, and she is going to be in the chat box and chatting you up there. But I think not only chatting, but she'll be sharing some important links with you related to topic that we're covering tonight. And so this way, anything is on the screen and we have programs or their sources, you'll have the links to those right in the chat box. So we want to welcome you to the third and final week and the second to last day of the International E3 Summit, Educating, Empowering, and Enriching Our Community, brought to you by the Marfan Foundation and our divisions, the Loeys-Dietz Syndrome Foundation and the VEDS Movement, and our partners in Europe at the CERN. Thank you all for making this summit so historic. We actually hit 2,800 registrants last night. Today we may have a couple more, but you guys have come from all over the world and we see so much activity and connections going on in the community boards in the app, and we think that's amazing. And we hope that you will stay connected afterwards and keep talking to each other and participating in things and getting to be a stronger community. And you can do that actually through Walk the Wonders, which is a new program that we announced today. You can check the app because there's an announcement that just went out about it. We're really excited that this has been such a big and successful event and that we've been able to give all this information to all of you. We want to thank our presenting sponsors, Brigham and Women's Health and American Communications Construction. Because of their support, we're able to do these programs like this. And with this summit, we're able to do it for all of you at no charge. And that's because of our sponsors. So thank you so much to these two presenting sponsors. Before we start this particular program, I just want to remind everybody that the International Summit is a forum to provide an open discussion of issues related to genetic, aortic, and vascular conditions. Opinions stated in each of these talks are those of the speakers and not necessarily the opinions of the Marfan Foundation or BCERN. If you hear differences of opinion from speakers and want further clarification, please contact our help center at marfan.org/E3ask. And please be patient because, as I'm sure you're aware, the volume is high during this summit. So today we have three amazing speakers. Oh wait, well, before we get to our speakers, I have one more piece of information for you guys, and that's the surveys. Sorry, speakers, you need to wait one more minute. We have a session survey, and that is right in the app, right in the agenda where you're watching this session right now. If you just click on those where it says rate, there'll be a few simple questions. Tell us what you think about the session, and we really want your feedback. And there's also a survey that's now available about the entire summit. So we'd like to hear your opinion on that. We're going to selectively pick three survey participants and give them prizes: a $50 US gift card that's good internationally, and that will be they'll be selected from everybody who submits their survey by Wednesday night at 11 p.m. Eastern time. Now we can get to our presenters. So I have three amazing presenters here today. We have Dr. Melissa Russo. Do you want to say hello, Melissa?
Hi.
And you'll be hearing from her later. And then we have two parents who are here to share their stories. They have their parents with separate spouses, so they each have different stories. We have Maya Brown-Zimmerman and Adam Bitterman. So we will get to those stories first, then we'll hear a medical presentation. So I'm going to ask our speakers to shut off their audio and their video, and I will do the same. I'll mute myself.
Hi, I'm Maya Brown-Zimmerman. I'm mom of 4 kids, a parent through both biology and adoption. My husband Mark and I looked at multiple avenues for building our family. At the end of the day, we decided that the inherent nature of parenthood is that it's not without risk. And I feel like I have a pretty good life. If we had a child with Marfan, I felt like they could have a good life too. And we felt equipped to be able to handle whatever issues might arise. And honestly, I really wanted to experience pregnancy. After 2 kids, one of whom has Marfan, a combination of complications from my pregnancies and secondary infertility led us to adoption. Miles is 11, and I developed very high blood pressure at delivery, which lasted for 3 months postpartum. We think it was preeclampsia, although I was never tested for it. Julian is 9, and I had a lot more pain during that pregnancy, including contractions that started at 24 weeks. I also developed lymphedema in both legs after delivery, which has not gone away. But my aortic growth was minimal. I breastfed both kids while on atenolol with Miles and on losartan with Julian. Now, I could talk all day about adoption, but what I'll initially say is this. I hear, just adopt, said often, especially in the context of building a family within the Marfan community. But there is no just when it comes to adoption. My love for my children is the same, but the experience is different. Adoption means truly being okay with the fact that your child will always have a second set of parents, whether or not you see them or you know much about them. We adopted Ruby within the US using an agency. It took 2 years, 2 months, 1 week, and 4 days from the time that we were home study approved until we got the phone call about her. We adopted Eliza privately, so without an agency, and we were matched with her before our home study was completely updated. Having Marfan was not an issue as far as being approved to adopt in the US goes. But if you're looking at international adoption, it will exclude you from some countries. I'm happy to answer any questions about my experience with pregnancy and adoption or with general adoption questions.
Hello, everyone. My name is Adam Bitterman. I'm an orthopedic surgeon on Long Island in New York. I have a diagnosis of Marfan syndrome. Today, I'd like to talk to you all about the concept of family planning and having a family. I'm fortunate enough to have a wife and 2 children. With my diagnosis, my wife and I had a lengthy conversation on the possibility of family planning. and I chose to make what we thought was a medically responsible decision in order to limit the transmission of Marfan syndrome to our children. In doing so, we both decided that pre-implantation genetic testing was the best method for us. Please understand that there is no right answer, there's no wrong answer, there's no simple answer, but options do exist. With these options come concerns regarding finances, religious concerns, personal decisions, as well as insurance concerns. I will be here to answer any and all questions to the best of my ability. I look forward to speaking with you all.
Hello, my name is Melissa Russo, and I am a high-risk obstetrician and a clinical geneticist. And today I'm going to be talking to you about pregnancy and reproductive health in women with connective tissue conditions. So what is the definition of aortopathy? So this is any condition where the aorta is affected, and the aorta is the biggest vessel that's giving blood to our body and brain. And, when the aorta is affected, it can become larger, and there is a weakness in the wall of the aorta, which can be an aneurysm when it's pathologically larger. And when it's larger and weakened, this can potentially lead to a tear in the wall, which is a dissection. And this can be catastrophic for a person. So today we're going to be talking about the genetic causes of aortopathy and how women with these conditions can be affected during pregnancy. And those are women that have Marfan syndrome, Loeys-Dietz syndrome, vascular EDS or Ehlers-Danlos syndrome, women with bicuspid aortic valve, Turner, and finally, women that have familial thoracic aortic aneurysm and dissection genes. The ultimate concern for women with these conditions is that we think pregnancy and postpartum is potentially a higher risk time for an aortic dissection. So why is this the case? This is thought to be secondary to hemodynamic and hormonal changes that occur normally during pregnancy. These changes can potentially put increased shearing forces and stress on the already weakened aortic vessel wall. So during pregnancy, normally there is more blood pumping around the heart. The heart's going a little bit faster and it's working a little bit harder, and all these things can put more stress on your blood vessels in the aorta. And the biggest time in these changes is really peaking in the third trimester of the pregnancy, around 30 to 32 weeks gestation. Hormone levels also change during pregnancy, where estrogen and progesterone start to go up in the beginning of pregnancy and then continue to increase with increasing gestational age. There has been previous studies where they looked at 2 women who had arterial dissections during pregnancy, and we found that there's actually microscopic changes that occur in the blood vessels if you look at the lower right corner of this slide. And this is thought to be related to hormonal changes that occur during pregnancy. Looking at the large arteries, there's fragmentation of internal elastic lamina and loss of reticulin. Similar changes have been seen microscopically in women who have been on birth control for long term or animals who have gotten hormonal stimulation. Therefore, thinking about these things, we know pregnancy may be this higher risk time because there's changes in the cardiovascular system. There's also changes in hormones that could be attributing to pregnancy being this higher risk time for aortic dissection. So aortic dissection in pregnancy in women that have these conditions, I just want you to know that really this is still a rare event. It's not something that's occurring in all women that have these conditions. Some of the largest studies in Marfan and Loeys-Dietz syndrome have said that the risk is about 5 to 6% of women will have an aortic dissection in pregnancy, and this most commonly is occurring in the 3rd trimester or the postpartum period. And again, a majority of women don't have these complications. The biggest problem we have right now is we don't yet have a system or a method in place for us to help identify on an individual basis when you're sitting in our office who is going to be the person that has this aortic dissection. We do currently know that based on previous studies, there are some risk factors for aortic dissection. The main one is sort of looking at your aortic root size on imaging, with 4 centimeters sort of being the threshold that puts somebody into a higher risk category versus a lower risk category. If it's greater than 4 centimeters, we think that risk of dissection is about 10% in the pregnancy versus less than 4 centimeters, we think the risk in pregnancy is about 1%. Other risk factors that have been identified are if there's rapid aortic root growth during the pregnancy, so that's why it's an important thing to watch the aorta during the pregnancy with imaging. And then if a woman has baseline high blood pressure or develops something called preeclampsia, where you can get high blood pressure just in pregnancy, these have also been identified as risk factors. And we're now starting to ask women additionally, and there's not really good data yet on this, but you know, if there's other women in your family who have had the same condition and how they did during their pregnancies, thinking that in the future this may be something that we will use to really help calculate somebody's individual risk. There's a huge gap in knowledge, like I talked about how to identify women on a one-on-one basis in my office of what is their risk of an aortic event in pregnancy, or what is the chance that that's going to happen to them. And we are doing ongoing research really to better answer these questions. And again, I just want to reiterate, because I keep talking about aortic dissection, but really a majority of women are going to have a safe pregnancy where they don't have this event. But the reason we keep talking about it is because it can be life-threatening to the mom or to the baby, and this is something that we definitely want to prepare for in a pregnancy. So how do we help plan for a pregnancy or prepare? So the biggest thing is before you decide to get pregnant, talking to your doctors. And these are your cardiologists, or meeting with a high-risk obstetrician or a geneticist prior to getting pregnant, because we want to transition off of certain medications that could affect the baby, such as angiotensin receptor blockers like losartan. Potentially, if you're on some types of blood thinners like Coumadin, those are also medicines that we want to get off before we're pregnant, and transitioning on to other medicines like a beta blocker like metoprolol. The other thing we want to do is get baseline knowledge about the body in pregnancy. Looking at doing CT scans, which are some imaging we try to avoid if possible, and then MRIs. And we want to just get this information so we can, again, look at the size of the aortic root and then give you better counseling about how to, what your risks are in a pregnancy. Genetic counseling is also important, which I'm going to talk about more on the next slide, as a majority of these conditions can be passed on to your baby. And talking about just contraception, because if you do have a condition like this, we want you to get pregnant at the right time and when you've been planning for it. So contraception is really important, and we know that women with any kind of chronic conditions have a higher risk of unplanned pregnancies, because that's not actually something that's being focused on with your health care necessarily. And so it is really important to talk to your doctors about contraceptive options if you're not wanting to get pregnant or it's not the right time. In some cases, I'm going to talk about this on a later slide, we do want to discuss talking about surgery prior to having a pregnancy. So talking about genetics and genetic testing options in a pregnancy, a majority of the conditions that we're talking about today are autosomal dominant, which means that if one parent is affected, they have a 50% chance of passing this condition on to children. The exception to this rule of autosomal dominant is Turner's syndrome is an X-linked condition. Some people, knowing that there's a chance of passing this condition on to their children, they want to pursue genetic testing in their offspring, and this is a really personal choice. This is not something you have to do, but it's definitely something a lot of people ask questions about. Some individuals want to know this information for pregnancy planning because they would choose to not continue a pregnancy if they know that it's affected with the same condition. Some people just want this information to plan, and some people decide, I don't want to do any kind of testing and I'll just test my child once they're born, if need be. If you are interested in testing your baby, the thing we need to know is we need to know your specific genetic change in order to do a test. And so if we don't know what gene change you have, we are actually not able to do any kind of genetic testing on a pregnancy. So this testing can be done in the embryo prior to implantation into the uterus versus doing this during a pregnancy. If testing is being done in the embryo prior to implantation, this is called pre-implantation genetic diagnosis. It involves a reproductive and infertility specialist where they put the sperm and the egg together in a petri dish to make the egg. They have to freeze it and test it, and then they'll only put back babies that are unaffected with the gene change. And this can be put back into the mom. And if she is affected with the condition, she can also choose to have someone else carry this embryo. Genetic testing can also be done in the pregnancy. During the first trimester, it's chorionic villus sampling. Second trimester is amniocentesis. And there's a small risk of losing your pregnancy with these procedures, but it is relatively safe. And this is really weighed against the risk of wanting to know during a pregnancy. So the main things that you're going to talk about in the office in terms of risks related to pregnancy come down to obstetrical risks and also cardiac risks to the mom. And so with the majority of these conditions, the things that we've already talked about are that the aortic root can dissect or have a tear, and also the aortic root size can grow with pregnancy. Previous studies have shown this. Most of the time, the aortic root does not grow very much in a pregnancy, but we're just not really ever able to guarantee that to a woman. The other thing that has been described in Marfan syndrome is some women also can get arrhythmias during the delivery process. Obstetric things that we talk about typically are that you may be at a higher risk for preterm birth or preterm rupture of the sac of water around the baby, and fetal growth restriction, where the baby can become small, is something that is more common in women that take beta blockers, but when we're weighing risks and benefits, we think that the beta blocker is something that a woman should take during the pregnancy. Uterine rupture is mainly a risk when we talk about vascular EDS, where the uterus can actually just open during the process of labor and contractions, and for multiple reasons, cesarean delivery is recommended in these women. And for Turner syndrome, we recommend that women we think are at higher risk to get preeclampsia in pregnancy, and we have some other things that we want to do in terms of giving them like a baby aspirin during their pregnancy. The obstetric risks haven't really been classified well for bicuspid aortic valve and familial thoracic aortic aneurysm and dissection. Just because we don't have enough data yet. We do know there's the risk of aortic dissection, but the other obstetrical risks really haven't been fully detailed. So we want to use a multidisciplinary approach when you get pregnant with your high-risk obstetrician, the cardiologist, cardiovascular surgeon, doctors, pediatric doctors, and nurses from all specialties, delivering at a hospital where there is cardiac surgery available in the case you do have an emergency. And then lots of education, contingency plans, and simulation of the whole team is important. So during the pregnancy, the main things we want to talk about is that we want you to be on a beta blocker. Preferably metoprolol is what's preferred because there's the least chance of a baby becoming small with this medicine. Imaging of your aorta during pregnancy with echocardiograms, which are safe, and then the MRIs without the contrast are safe during pregnancy as well. For the baby, we want to do a detailed anatomy ultrasound with growth ultrasounds every 4 weeks in the third trimester. And then we sometimes can see if a baby's affected with signs on ultrasound, and a fetal echocardiogram is recommended in those cases. But a lot of the times, especially with Marfan syndrome, we cannot see anything on ultrasound to tell us if the baby is affected. Talking about anesthesia, spinal imaging is key because women can have scoliosis, things called dural ectasias, or they can have other vascular anomalies in the spine. And anesthesia during your delivery is really key for two reasons. One, we want to decrease pain to help you with pain, but because when you have pain, you can have high blood pressure and your heart rate can go up, and that all can put more stress on the blood vessels, and we're really trying to avoid that. Secondly, we want to do an assisted vaginal delivery with a forceps or a vacuum, and we do want to have anesthesia for that. And thirdly, we want to be able to move to the operating room quickly if need be. And these are the three reasons we really want you to have some type of anesthesia during your labor course. With the dural ectasias, which are the outpouchings in the sac around the spine, regional anesthesia can be used, but we need to know about this ahead of time because sometimes the medicine does not work as well. And with Loeys Dietz, we want to rule out cervical spine instability with x-rays as well, in case you would need to have general anesthesia. For delivery recommendations, we have not really determined the ideal time for women to deliver to really prevent some of these complications. But we think typically we recommend delivery about 1 to 3 weeks prior to your due date. The type of delivery is also going to depend on really a bunch of factors of like who you are, how healthy you are, and how big your aortic root is and what your team has determined. Vaginal delivery is safe for a majority of women, and we do decrease the amount of pushing because that can actually put pressure on the aorta as well. So we sometimes will help with the vaginal delivery using forceps with a vacuum. And C-section is recommended in some cases. Postpartum, so we talked about the highest risk times were third trimester or postpartum. So we do want to make sure that women are observed for a good 2 to 3 days after their delivery. Depending on where you live, how far you are from the hospital, imaging after the delivery may be done while you're still in the hospital recovering from your delivery versus an outpatient basis. And then we want to follow that every 3 to 6 months. There's been a lot of questions and talk because I think for a long time we've known, and now we have good data from Hal Dietz's lab that, the Marfan model of Marfan syndrome, the mouse model of Marfan syndrome, there's oxytocin, we think, which is the hormone that sort of helps with milk letdown, is contributing to aortic dissection risk in these mice. And the question is really, is there the same effect in humans? And we do see that the majority of dissections in humans are occurring in the third trimester or postpartum. And so there is this concern that breastfeeding could be potentially putting people or humans at higher, have great human data yet. And so I think my recommendation really is, and I'm happy to answer questions during the live session about breastfeeding, but I think if you want to breastfeed, I think you have a conversation with your doctor and know that we do know that in mice, we think that, milk letdown may have something to do with putting you at higher risk for a dissection, but we don't know that yet in humans. And we're working on that data. And if you do want to breastfeed, just follow with your doctor a little bit more closely. And if you have any symptoms of dissection, you need to come to the hospital immediately. For women that have had aortic surgery prior to getting pregnant, this is another conversation. And we do have some data that women can do well in a pregnancy, but the important thing is that you have to have surveillance. Even though the aortic root has been replaced, that does not get you out of the window of being safe. You can have dissections beyond the graft, and this is something that needs to be monitored during pregnancy. There's been small studies that have looked at this, and potentially we think the women that are going into pregnancy with the prior aortic root surgery are at higher risk to have another event, and pregnancy precipitate or increase those risks. We're not fully sure, but there have been a good handful of women now that have had successful healthy pregnancies after having aortic root surgery. So again, this is something you talk with your doctor on an individual basis. And my last two comments are really just the most common thing I get asked is it safe for me to have a baby? And I know I just ran through lots and lots of things quickly, but I want to just tell you that there's not a quick answer for this, and it's really sitting down and having an individualized conversation with your doctor before you decide to get pregnant, because there's a lot of things to consider, and there's a lot of different ways to have a child. And I just want to leave you with that a majority of women can have healthy pregnancies, but again, this is a very individualized conversation, and your decision to become a parent is a very personal one, and there's lots of different ways to become pregnant. And we are happy to sort of discuss with you all of these options and try to have the healthiest pregnancy possible if you decide to do that. Thank you very much, and it's been a pleasure speaking to you, and I'm excited to answer your questions.
Thank you so much, Melissa. That was great. And so I'll ask you to put your camera back on, and I will as well. And I know before we go on, there are lots of questions. And so I think some of them were answered in the session, but they're definitely worth going over some of the highlights here because, people do want to know a lot of information. But I know first, Melissa, you want to talk about some of the studies that are going on related to pregnancy and connective tissue conditions.
Yeah, so these are things that I want people to be on the lookout. I mean, people ask, how can I help improve care for women? And really that is volunteering to be part of studies. We have a bunch of studies that are going to be starting very soon. One is actually an international study, which I'm really, really excited about. Dr. Bart Loeys is the investigator that's really going to be heading up a lot of the international work on a survey. And that will be available eventually on the Marfan Foundation website. And so we'll also send that out through social media once it's available. If you want more information about that, I put my email addresses up here. And then there's a second study that I just got IRB approval for, which is just like the ethics board you have to apply to get research. And this is really looking at the psychosocial and mental health issues related to having a pregnancy when you have a connective tissue condition. And so I'm really excited about this because I think this really hasn't been looked at all in the past. And so that is going to be appearing hopefully soon for anyone. The criteria for that is if you are thinking about having a baby in the next 5 years, if you are currently pregnant, or if you've had a baby in the past 5 years. But I think that we're really excited to sort of look at some of those issues as well, because I think those are really important health issues. And then there's an ongoing study that's going on at 7 different institutions in the US where we're collecting really detailed information about pregnancy, really trying to identify more of the risk factors and problems that occur in pregnancy with women with all kinds of connective tissue conditions. And the next phase of that is hopefully going to be prospective. I feel very, very lucky that the Marfan Foundation has funded that study, which is ongoing. And if anybody has questions, again, these are my email addresses for studies, or if you have any questions related to anything you want, like a personal advice about related to pregnancy or women's health.
Wow, that's great. Actually, there are a couple of pregnancy studies on our website now, and Helene is putting the link to that page in the chat box. And when your studies are IRB approved, those will go on that same page. So it's putting that in there. The other thing she's putting in there is the link to join Backpack Health, which is our international patient registry. And so, we talk about, I think you said at least one time in that presentation that you just need enough patient data and you need a big cohort so you can do the studies. And through Backpack Health, if people put their information in, they consent to be included in research studies. Their information will be, aggregated. It'll be combined with other people's. It'll be de-identified, and then researchers such as yourself will be able to get their information. So Backpack Health is the foundation's registry, and that link is in the chat box here too. Okay, so let's go to the questions. So let me just look at that off of there, and I will put you. I'll stop sharing so we can see you all. That's even better. Okay, so we're going to get right into it, and some of these things, like I said, you have talked about a little bit. But Melissa, can you tell us a little bit more about what the research says about Loeys-Dietz syndrome and pregnancy?
Yes, that is a big topic, but I think some of the early papers and research really was thinking that, pregnancy was not a good idea for women with Loeys-Dietz. But again, I think the spectrum of what we've learned is that there is definitely a range of mild and more severe disease. And I think, again, you can have a really healthy and safe pregnancy. It all is a very counseling on an individual basis. I have seen a lot of women with Loeys-Dietz who have had healthy pregnancies. and successful pregnancies. And I've also counseled people who have decided to have a gestational carrier, which we didn't really talk about. And I'm sure Maya can also like talk about this a little, and she didn't do that, but anyways, there's a lot of different ways to have babies where you can potentially use your own embryo, and some gestational carriers where you use your own embryo, but another woman carries the pregnancy. And just like Maya talked about, just adopt, just do a gestational carrier is not a just at all. It is a very complex financial, emotional thing for someone else to be carrying your child. So it's not an easy decision, but it is an option that is out there.
So a lot of these questions are really about all the different ways to build your family, create your family. And you did touch upon a lot of things to hear, but I want to do this live because this way you can tell us a little bit, and then we can hear from Adam some of his thought processes and more about Maya from her thought processes. So IVF. So let's just talk about IVF a little bit and the pre-implantation genetic diagnosis, because you see the data on the slides and you see it's an option. Maybe even hear a little bit about how it's done, but there's a lot of things that go into it and a lot of questions you have to ask. So can you just tell us a little bit from the medical side, Melissa, go into it a little bit more, and then maybe Adam, you can weigh in on some of the, you don't have to get too personal, but just some of the thought processes there.
Mm-hmm. And Adam can speak to this too. So from the medical side of things, I think it's worth, again, sitting down with someone before you would go through the process. Basically, typically what they do for IVF is you get your hormones, these hormone injections, which sort of, if you are the one, if the woman is the one that is, has one of these conditions, and she's gonna do IVF for, infertility, for doing genetic testing or something like that. All these extra hormones, they do that so that you have more than one egg available for them to use in a cycle. And with those extra hormones, we don't yet know if that in itself is a risk factor for a problem. There are ways to do IVF where you use an estrogen blocker as well, called letrozole. So I think from a maternal standpoint, you just need to think about that if you're going to go through IVF. And the medical, we sort of talked about it, but really this is where you get the sperm and the egg in a petri dish. A woman can use her own egg, or she can use a donor egg, or you can use donor sperm or your own genetic material to make a baby in a dish. And then if you're gonna do genetic testing, this baby has to be, or the early cells have to be frozen so they can do genetic testing. I talked about in the slides how you really have to know your mutation to be able to do this testing. So that's really important because some people have not yet had genetic testing for their conditions. And in terms of like getting to insurance and talking about those kinds of things, genetic testing in itself on the embryo can run anywhere from $2,000 to $3,000. And sometimes this is covered by insurance, but it depends. I think that's something also to look into, the costs of these things, because in some states, fertility is covered when you, or IVF is covered if you're doing it for infertility. I think insurance companies are becoming more progressive and covering it for genetic conditions, but that is a newer thing. And so it's always worth looking into what the costs of this will be, because it is a financial, it is definitely a financial, I don't know what the right word is now, but it is a lot, be a lot of money. And I think those are the main things.
Yeah, so I wanted to go to Adam because when we chatted about this a couple weeks ago, and obviously a lot of things are divided, you have to decide for yourself, but there's a lot of things that people don't really think about going into it. Like how long is the process? What were some of the deciding things for you? Now in your situation, you're the one who has the condition and your wife doesn't. So can you tell us a little bit about that or what you feel comfortable sharing?
Sure, of course. So I'm definitely the outlier for this session. I think I'm the only male here, so I have to be careful what I say.
We love you anyway.
But don't worry, my wife is nearby, ready to pinch me and kick me. Nonetheless, it's certainly the opposite, where I'm the affected one, she's not. but the thought process may be similar. So like I said, I have a physician background, so my thought process was what we wanted to do. Again, a very personal decision was to make what we thought would be a medically responsible decision in an attempt to try and limit the chances of passing it on. And by doing so, we chose the IVF route. Now, as Melissa was saying, they needed to find out the exact genetic malformation, and they needed to take my DNA, and then they needed a parent. The problem, or they needed multiple parents or family members. And that can become an issue if it's outside of your parents. And for me, it was because my dad had passed. But outside of that, we had to go to uncles. And it can be a little awkward if your uncles or other family members are not aware of full genetic disclosure. So that's part one. Number two is it's a conversation that you have to have with your reproductive specialist, and it takes a little bit longer than I initially thought. I don't remember the exact time frame, but I think it was about 3 months in total from start to official pregnancy, if you will. And as Melissa said, it's a lot of money. I think ours total, don't quote me on it, was about 6,000 or so. But anyway, the insurance is a component that needed to be looked at. And as she said, it's a combination of sperm and egg, and then that embryo then goes to a lab, and that lab then has the job of testing these embryos to find out which are able to be used and which are not able to be used. And then from there, you then do the injection, or that's not the right word, the implantation. So that's a whirlwind response, but I want to sort of keep it brief so other questions can be asked. But that's my perspective. Again, it's the opposite as was mentioned, but certainly there's a lot of similarities.
Yeah. And there are also questions in here about some of the other options. So Maya, if you could maybe go a little bit more into the choices that you made. You talked a little bit about it in the video, but if you could tell us a little bit more about, you know, your situation, you know, having, you know, building your family in different ways.
So initially we looked at kind of all the different options. So we looked at PGD and what that would cost and what that would look like. We looked at gestational carriers and what that process would be like. And we looked at adoption, and then we talked with my medical team, kind of went through the different doctors, met with the cardiologist, met with the Dr. Sponseller, talk about my spine and dural ectasia to get everybody's approval. And I felt more comfortable going forward with pregnancy based on my aortic measurements and kind of how my rate of growth had been going. And then the fact that I was going to be working with a maternal fetal medicine specialist who specialized in cardiac patients at a hospital that had a cardiac surgeon and a team ready, you know, if something were to go wrong. After we had our second son, and I had a more complicated pregnancy, it was recommended not to try a third time. And I had other medical issues as well. So we looked into adoption and all the different avenues for adoption, and went from there.
That's awesome. That's great. You know, you brought up a point that somebody asked a question about, and that is spinal issues and how that might affect you having the pregnancy. I just want to look for the exact, here, I want you to find the exact question. What complications can a Marfan syndrome patient with moderate to severe scoliosis expect with pregnancy and delivery? Do you ever see that, Melissa? And do you ever see that?
Yes, sorry. I mean, because I think Maya can weigh in too about like spinal issues in pregnancy, but the main issues that can cause is if you have severe scoliosis or you have any kind of rods in your spine, then it may be harder to get that anesthesia. And so that may affect the way you would be counseled about delivery. And then I think from a practical standpoint, I'm going to hand it over to Maya. I think that if you have already spine issues or you have pain or different things, then what happens when you're pregnant, and I usually like act this out, but your belly, you know, becomes bigger, and the curvature or sort of like the lordosis at the bottom of the spine, because you're holding this bowling ball in the front of your belly, and you sort of lean back on your spine a little bit more. So, you know, a pregnancy can really just put a lot of pressure on joints going through the pregnancy. And one of the hormones actually makes your joints a little bit more lax on purpose to allow your body to birth a baby through the pelvis. But that can affect already people that have issues with joints or pain. And now I'm going to hand it over to Maya because she can probably speak more to you about what it's like to have Marfan syndrome and then go through a pregnancy talking about spine and joints.
So I have scoliosis in the lumbar region of about 40 degrees. So I don't have rods because I haven't had surgery for it. And then I have moderate dural ectasia. So with my first pregnancy, there was definitely some back pain, although it wasn't terrible. But we had a whole team meeting with anesthesia to decide what the best way to move forward with delivery. And at the hospital where I had my first child, the anesthesiologist had not dealt with dural ectasia before and was not comfortable messing with it. He didn't want to risk having a cerebrospinal fluid leak. And so he insisted that we do general anesthesia for my delivery, which was an interesting, you know, go to sleep, you wake up, and then there's a baby. When I delivered Julian, it was a different hospital, and we decided to go for a VBAC and ended up using a spinal catheter instead of an epidural when I needed an emergency C-section. But they didn't have any problems placing it. It was higher up. And so my scoliosis and dural ectasia were not an issue for that. But my back pain was way worse the second time around. And it worked out that I was on bed rest for the last 8 weeks because I really couldn't walk. I used a wheelchair if we went out anywhere.
Wow. Wow. Thanks for sharing that. Let's go back to before pregnancy. Melissa, how long should you be off losartan before getting pregnant?
Great question. Typically you want to have a washout, you want to be off of that medicine for 6 weeks or so prior, and that's not something you should just do by yourself. You want to make sure you work with your cardiologist to get sort of transitioned onto another medicine before you would really stop that losartan. But the minimum amount of time we usually say is 6 weeks.
And what about the age of a woman with Marfan getting pregnant? Would you advise them to get pregnant younger, or does age matter?
In general for pregnancy, yes, unfortunately, as somebody that delayed childbearing themselves. The older you are as a woman, you're just at higher risk for, not really necessarily related to Marfan syndrome, more related to your age. A higher risk of diabetes in the pregnancy, high blood pressure in the pregnancy, needing a C-section. So, you know, it's easy to tell all of us as women to just, you know, have your babies in your 20s because a lot of people have other plans for, you know, work and career. And, but yes, I think the younger you are, the better, but I don't think it's necessarily related to Marfan. It's more in general. We tell women that.
I'm going to go back to an IVF question and ask this to Adam. If somebody does want to go into to pursue the PGD IVF option, how do you evaluate clinics? What questions should you ask when you're looking for the right specialist to do this?
Great question. And I get this also with my orthopedic conversations, because I think, and Melissa may be able to correct me if I'm wrong, but not everybody knows the ins and outs of the connective tissue disorder or the aortopathy, unfortunately, and that may be for a variety of reasons. So my first go-to answer, regardless of where you are, is to find someone that you're comfortable with and someone that you and your spouse can relate with. And then you have to ask them point blank if they understand the condition, if they understand your goals. And most of the time, you need to seek out an academic center. And generally speaking, those tend to be in major urban setting rather, in the big cities, or there's the big academic centers that are throughout the country. And generally speaking, again, don't quote me on that, but you can be successful. And I am happy to go offline and give my center. It's kind of based on my location. I'll leave that part out, but they're all across the country and they all do great work.
Great, thank you.
If I can add one other thing, that if you're a woman with Marfan trying for PGD, what a lot of women are finding is that private clinics won't take you because you're a high-risk pregnancy, even though you're not necessarily high risk for the time that you're with them, for the first trimester. And so you pretty much have to go to an academic center for that reason.
I think the other thing too, from like a medical legal risk, is a lot of the infertility specialists won't put an embryo back in a woman until they've seen or had a consult to say that they are quote unquote safe to have a pregnancy as well. And so you may need to see or get, a consultation from your doctor or from a specialist to see an infertility or endocrinologist.
Great. All right, so we're gonna go back some cardiac medical things here, Melissa. What has been your experience, or what can you tell us about pregnancy after medically managed abdominal aortic dissection and surgically repaired thoracic aortic dissection? Because a lot of people with Marfan are having, all these surgeries late teens, early 20s, and before they're ready to have children. So what would you say about that? I know that's a tough one.
Yeah, I think it's one of those that is a really, to tell the entire group, I mean, if I understand correctly what you said, if you've already had a repaired thoracic and you have like a chronic or a type B dissection as well, I mean, I think it's a very one-on-one conversation about the risks that would be associated with the pregnancy. I think you're probably someone that's more in a higher risk group with that information. I never will say to someone like, you should not have a baby. I mean, there's very few situations where I would say you should not have a baby. I'm happy to have a conversation with whoever asked that question offline, because I think before I would know all of the history, I wouldn't want to say, exactly what I would recommend. I think that you're just in a higher risk group with that information.
What about, this is sort of related, and what's the risk of dissection? They didn't say during pregnancy, but I'm thinking it's during pregnancy since
yeah. I mean, I think the biggest concern is that if you have a chronic type B dissection that's ongoing, it may all of a sudden start to get bigger during pregnancy, which could be a concern, where most of the time we manage type B dissections with medicine. I have seen 1 or 2 cases where women have required surgery when that type B dissection in pregnancy got bigger and bigger and bigger during the pregnancy. So that would be something that I'd be potentially concerned about and want to follow closely.
Okay, so here's a different person wanting to know the risk after open heart surgery to repair the aortic root aneurysm. There's no type B involved there. They've had it repaired.
Yeah, so I mean, interestingly, one of the things we talk about is if you have a root that's bigger than 4 centimeters, 4 to 4.5 centimeters, we talk with women about getting their root repaired before you would consider a surgery. And, it's a small group, but a majority of the women that we've looked at who have had an aortic root repair go on and can have a very healthy pregnancy. But in these there's 2 small groups of women that have been studied. Depending on why you needed that surgery in the first place, whether it was an emergent thing or it was done sort of in a more controlled manner, matters. And that can affect your risks. And then, you know, you potentially, because you've had that repair, are at higher risk to have problems beyond the graft.
You had some great charts in that. I'm definitely going to ask you for those PowerPoints. I love the way you organized everything by condition.
Yeah.
Because obviously we have a wide range of people, you know, in this session. Somebody's asking if there's more information about pregnancy with bicuspid aortic valve or familial thoracic aortic aneurysm disease.
Yeah, I mean, we have less information, and I think our sort of the group that's been studied the most are women with Marfan syndrome, and then we sort of extrapolate from there. There is good data that women with bicuspid aortic valve are typically not higher risk till they get to about 5 centimeters. And so, you know, we would sort of follow them the same way we would with a woman that has Marfan syndrome or Loeys-Dietz, and sort of the same kind of rules apply when we're thinking about how to deliver someone. If you have a bigger aortic root, then we do a C-section versus a vaginal delivery.
Mm-hmm.
We don't really have great data to say that that C-section is actually protective. That's just more of expert opinion at the moment. And they're not necessarily at risk for the spine issues, though. It's typically just their heart that's affected. And then for the women that have changes in genes for the familial thoracic aortic aneurysm dissection, again, not a lot of data, meaning we haven't studied a lot of women, but the biggest concern in those women is there's not really, the same rules don't apply. Some women, it doesn't really matter the size of their root going into the pregnancy. People have had dissections at smaller roots. And so we don't really know the risk factors as well in that group.
Okay. Let's talk a little bit about the postpartum challenges and breastfeeding. So what's safe, what's difficult, what are the challenges in that time period after the baby's born? Maybe Melissa, we'll start with you, then we'll talk to Maya.
So, you know, everybody always asks about the mouse data because that's been talked about for a long time. In mice that have Marfan syndrome, there is good data that, you know, when they're lactating and feeding the pups, that's not a good thing. Again, in humans, a majority of women, at least in the United States, and I think even internationally, like 70 to 80% of women do breastfeed their children for some amount of time. And so we don't really know yet if the same risk factor applies to humans. There's ongoing data to collect this information, and just, you know, that if you choose to breastfeed, just make sure that you are being followed closely. People know about your condition, and if you have chest pain or back pain, that you take it seriously and show up to an ER and get checked out. And I think just a majority of the people, or not a majority, but it's a very personal decision, just like everything else, whether you want to breastfeed. There are so many positive things about breastfeeding, and I think until we have really, really great data, I hate to tell people not to breastfeed.
Right. Are there any other postpartum challenges they need to worry about?
I think, you know, things we really haven't studied yet, which is just recovering after you've had a baby, and how it is when you've gone through a pregnancy and your body has gone through the pregnancy to then go home and take care of another human. On top of everything else, and sleep deprivation and all of those things, I think is difficult, which maybe, again, segueing to Maya, she can.
Yeah, Maya, talk about that for us a little bit.
C-sections are a major surgery, and I think sometimes people forget about it because they're so routine, but they're slicing into your abdomen, and you use your abdomen for a lot of things. And so it's a painful and long recovery. I mean, I've had 10 abdominal surgeries. So I had be careful about scar tissue and adhesions and things post-surgery, which I don't think is necessarily an issue for everybody with Marfan, but if you've had a lot of surgeries, like doing the second section, they needed to cut through some adhesions and stuff. And I did breastfeed, like I said, both of my kids, one on atenolol and one on losartan. We spoke with the Infant Risk Center, which is a clinic that specializes in studying medications during pregnancy and breastfeeding. And so they talked about the breakdown of losartan and atenolol, and it seemed like losartan went into the breast milk less. But my second child was also affected. So we figured there's a benefit potentially, if anything does come through the breast milk. And he was a little bit harder to nurse because of his low oral tone. And he had a lot of pulmonary issues. And so his team actually recommended breastfeeding for as long as possible to try to decrease his risk of respiratory infections. So we went a lot longer with him than with my first.
Okay. I'm going to ask you guys to all stay on your video because we're going to come back to you for some final thoughts, but we're going to go back right now to my final thoughts, and then we'll give you guys the last word with this session. So thank you for staying and answering so many questions. There are still a few more, but I'm not able to get to all of them. So if your questions were not answered, please submit them to marfan.org/E3ask. And our nurse will get back to you in time, give her a chance to catch up on everything that's coming in this week and the last 2 weeks. Again, please complete the session survey and also the summit survey. Please visit the exhibitors in our virtual exhibit hall. Like our presenting sponsors, they're really important to supporting this summit and all the work that the foundation does. So please go in there, let them know that you looked and that you appreciate them. That goes a long way. We hope that you're connecting with community and that you will continue to connect with community. We have our Walk to Wonders coming up that was announced this week. And so we hope you'll see you all walking to the 7 wonders of the world with us. If you don't know about that, check your email and look in the app, it's in there. If you would like to share some of the great experiences that you've had with us, our hashtag is E3Summit20 for social media. I know a lot of people are doing that, so please use our hashtag. And as always, if you would like to help us make more programming like this possible, your donations are always welcome, and that's the website there. Lane, I'm sure we'll be putting that in the chat box, marfan.org/donate, nice and easy. The other thing that's coming up is Aortic Disease Awareness Week, and the foundation is a leader in this worldwide. And again, we're doing our campaign to raise your hands, to raise awareness of the risk factors for aortic disease. And so we want you to submit your pictures. Again, that's on our social media, it's on our website, it's in the app, so you'll be able to do that and be part of it. We'll have some videos coming out during Aortic Disease Awareness Week, which starts on the 19th. So that is coming up as well. So before we end tonight, I just want to go back to our speakers and give you all the last word. Melissa, you want to have some final thoughts for our viewers tonight about building a family?
Yeah, sure. I think that really, in general, knowledge is power. And there are people out there that will help you if you do meet a doctor that sort of shuts you down and says, you can't have a pregnancy and just, you don't get along with them. There are plenty of people out there. So they just find the right person. And that's it.
Great, thank you. Adam, any final words?
Well, thank you
from the dad in the group.
Yeah, thank you for having me. I congratulate all the women who are on this call in the journey through becoming a parent. Obviously, I can't relate to you, but certainly it is something to be commendable. Certainly understand that there is no right answer. So what I chose, what Maya chose, what other folks choose is very, very personal. And I hope that tonight you learned one side or my side, and I'm sure, I don't want to speak for Maya, but I'm sure she feels the same way. I wish everyone the best of luck during this journey, and I hope that everyone is safe throughout.
Thank you so much, and we're really glad to have you here and willing to share your experience. Maya, final thoughts?
Thanks for the opportunity to be on the panel, and echoing what Adam said, there's no right way to build your family. And it's great that we have so many options these days. And so, connect with experts who can help you, look at all your options as you make your decision. And if you have any other questions for me, you can reach me through the app.
Great. Thank you so much. Thank you all for your time tonight. And thank you all for participating tonight. And we hope to see you tomorrow. You have one more chance to participate in another session. And we hope to see you there. Have a great night. Thank you all.
Bye.
Right.